Welcome my fourth year medical students. I am Dr. Karim Wahba, Professor of Obstetrics and Gynecology at Ain Shams University. Our lecture today will be on a very important topic which we will meet frequently in our clinical sessions and later on in our practice as medical doctors, which is antepartum hemorrhage. It will be discussed in two lectures. This is the first lecture or part 1. By the end of this session, you as a medical student will be able to define antepartum hemorrhage, enumerate different causes of antepartum hemorrhage, recognize the magnitude of the problem in Egypt and its contribution to the maternal mortality rate, take a full history of a woman with antepartum hemorrhage, perform the physical examination required for a patient with antepartum hemorrhage, interpret the investigations needed for a patient with antepartum hemorrhage, and determine what is needed in different situations, differentiate between the various causes of antepartum hemorrhage, manage the causes of antepartum hemorrhage according to the scheme outlined in Ain Shams University protocol, and lastly, identify the complications of placenta previa and abruption of the placenta. Antepartum hemorrhage is defined as bleeding from the genital tract occurring after the period of fetal viability and before the birth of the baby. The period of fetal viability is a bit variable in different areas of the world, and this will be discussed in details in the face-to-face session. It complicates around 3 to 5% of pregnancies. It is a leading cause of perinatal and maternal mortality worldwide and in Egypt. It is considered the 4th direct cause of death for mothers with an overall percentage of 7% in Egypt. Causes of antepartum hemorrhage are either from the placental side, and these account for 70% of the causes. The main two reasons for that are placenta previa and abruptio placentae. In placenta previa, bleeding is from an abnormally situated placenta, whereas in abruptio placentae, bleeding is from a normally situated placenta. The bleeding might be from an extraplacental site, and this accounts for 5% of the causes, as in cervical polyp, cancer cervix, varicose veins, local trauma, uterine rupture, vasa previa, which is bleeding of fetal origin, and general causes of bleeding. Sometimes antepartum hemorrhage may be unexplained, and this accounts for 25% of cases of antepartum hemorrhage. We sometimes call it marginal sinus bleeding, and this will be explained more in the face-to-face session. Speaking about placenta previa, as you all know from your physiology, placenta is normally implanted in the upper uterine segment or upper part of the uterus, more frequently on the posterior wall. But in placenta previa, it is implanted partly or totally in the lower uterine segment or lower part of the uterus. It complicates about 0.5% of all pregnancies. Risk factors for developing placenta previa include higher maternal age, multiparity, patients with previous cesarean section, cases with previous placenta previa, large placenta, as in twins, Rh isoimmunization, toxoplasmosis, diabetes, placenta membranacea. The theories of occurrence of placenta previa will be explained in the face-to-face session. This slide shows the classification of placenta previa into minor degrees, the two photos at the top, and these are grade 1 and 2, and major degrees, the two photos at the bottom, and these are grade 3 and 4. Grade 1, also called a low-lying placenta, top right, in which the lower edge of the placenta reaches into the lower uterine segment and within 2 centimeters of the internal os, but doesn't cover it. Grade 2, also called marginal placenta previa, top left, in which the placental edge reaches but doesn't cross the internal os. It can be called placenta previa marginalis, anterior, over the anterior wall of the lower uterine segment, or placenta previa marginalis posterior, over the posterior wall of the lower uterine segment. Grade 3, or partial placenta previa, or placenta previa centralis incomplete, in which the placenta partially covers the internal os. Lastly, grade 4, or complete placenta previa, or placenta previa centralis complete, in which the placenta completely covers the internal os. From its names, definitely major placenta previa causes more problems than minor placenta previa. Bleeding in placenta previa happens as a result of gradual changes in the cervix, together with elongation of the lower uterine segment. This applies shearing forces to the inelastic placental attachment site, leading to partial detachment. You need to remember at this point that the lower uterine segment develops from the isthmus, which is the distance between the anatomical internal os above and the physiological internal os below. This is about 4 millimeters in the non-pregnant uterus and reaches up to 10 centimeters in length at the end of pregnancy. Bleeding can be precipitated by effort, coitus, or vaginal examination. The higher the grade of placenta previa, the higher the risk of complications. Placental migration will be discussed in the face-to-face session. The main symptom is bleeding late in pregnancy. The bleeding is usually bright red in color and is usually painless, causeless, recurrent, but it may be painful if the patient entered into labor. It may be due to a cause as coitus or vaginal examination. It may be not recurrent if severe and ended up in delivery or death. General condition is quite variable depending upon the amount of blood loss. The patient might be not affected at all, anemic, or even shocked. On abdominal examination, the fundal level is equal to the period of amenorrhea, but sometimes it might be larger than the period of amenorrhea in cases of diabetes, Rh isoimmunization, or twins. Fundal and umbilical grip will show a soft, non-tender uterus. Fetal parts are well felt, and this is very important to differentiate it from cases of accidental hemorrhage, as will be seen later on. In the pelvic grip, malpresentations and non-engagement are common. Placenta, if anterior in position, is felt as a suprapubic bulge, as the placenta is occupying the lower uterine segment. By auscultation, fetal heart sounds are either heard, or in case of severe bleeding, intrauterine death, fetal death might have happened. There might be fetal bradycardia in cases of fetal distress. Definitely no pervaginal examination should be done at all. Regarding the investigations, the gold standard in diagnosis of placenta previa is ultrasound. Placental localization is done at 20-week scan, and if placenta previa is diagnosed at that time, a follow-up scan is done in cases of minor placenta previa and asymptomatic cases at 36 weeks. A follow-up scan is done in major placenta previa and asymptomatic cases at 32 weeks and then repeated at 36 weeks. In cases of suspicion of placenta accreta, more follow-up scans are needed. If bleeding happened at any time, the frequency of scans is increased. Ultrasound is also important for detecting the gestational age of the baby, estimated fetal weight, amount of liquor, any major congenital anomalies, and malpresentations. Investigations include also MRI and color Doppler, especially in cases suspicion of placenta accreta or morbidly adherent placenta. Lab tests include a CBC or a complete blood count, blood group and Rh, and other routine antenatal investigations. Tests of fetal well-being include the non-stress test, biophysical profile, Doppler ultrasound to detect fetal distress, especially if the bleeding is moderate to severe. And this is to plan the proper management of the case. Maternal complications of placenta previa include anemia, especially if recurrent episodes of bleeding happened, hypovolemic shock in cases of single episode of severe bleeding, abnormal adherence of the placenta, that is to say placenta accreta, and this will be discussed later in further details, preterm labor, either iatrogenic due to severe bleeding or due to fetal distress, or actually the patient entered by herself into preterm labor. Preterm premature rupture of membranes, malpresentations and non-engagement due to placenta occupying the lower uterine segment, postpartum hemorrhage, either atonic, traumatic, or due to retained placenta, puerperal sepsis, or recurrence of placenta previa in future pregnancies. Explanation for the various complications will be discussed in the face-to-face session. Fetal complications include increased perinatal morbidity and mortality due to preterm labor and preterm premature rupture of membranes, intrauterine growth retardation due to hypoxic insults as a result of repeated bleeds causing placental insufficiency, intrauterine fetal death, slight increase in the rate of congenital fetal anomalies. Management of placenta previa depends on four things: severity of bleeding, gestational age and fetal maturity, is the patient in labor or not, is there fetal distress or not. The prerequisites for the conservative management of placenta previa include mild or moderate bleeding not affecting the general condition, and the gestational age is less than 36 weeks, and the patient is not in labor, and there is no fetal distress. Conservative management includes rest, observation, and reassurance, adequate hydration and nutrition, cross-matching blood, correction of anemia, either in the form of iron tablets, iron injections, or blood transfusion, anti-D injection for Rh-negative women, antenatal steroids. Usually, they are given between 24 and 36 weeks, and is either in the form of dexamethasone or betamethasone, given in a dose of 24 milligrams over 24 to 48 hours. They are given intramuscularly. Maximum benefit from the steroids is seen between 24 hours and 7 days after administration. Steroids accelerate the lung maturity and hence decrease the incidence of respiratory distress. Tocolytics are not recommended, especially if there is active bleeding, as many tocolytics are vasodilators and this might increase the blood loss. An important question is when to deliver, either if there is severe bleeding or the gestational age is more than 36 weeks, or there is fetal distress, or the patient is in labor, or there is other indication to deliver, for example, as in cases of severe preeclampsia. Definitely, if bleeding is affecting the general condition of the patient, resuscitation is the first step of management and will be discussed in details in the face-to-face session. Caesarean section is the usual mode of delivery. There should be some precautions during the caesarean section, as the consent of the caesarean section should include risks of bleeding, blood transfusion, and the possibility of a hysterectomy. There should be an available high dependency unit with available blood bank and ICU. A senior obstetrician should undergo the caesarean section. If possible, cell salvage machine should be available. Opening the uterus should be away from the placental site, and the use of interventional radiology if possible. Further explanations will be discussed in the face-to-face session. Regarding the postpartum management, there should be aggressive treatment of postpartum hemorrhage if needed, and this will be discussed in details either in the postpartum hemorrhage lecture and also in the face-to-face session. Treatment of anemia is mandatory. Prophylactic antibiotics to guard against postpartum endometritis and puerperal sepsis. Anti-D injection in Rh-negative patients, and care of the neonate. This slide shows a flow chart of the summary of management of placenta previa. It will be discussed in details in the face-to-face session. Physiologically, there is a layer of fibrinoid material in the decidua bizalis that prevents placental trophoblast from invading into the uterine wall. If this layer is deficient, the placenta will abnormally invade into the uterus and cause abnormal or morbid adherence of the placenta to the uterine wall. The incidence is about 3 in 1,000 delivery. It happens in placenta previa, especially after caesarean sections. And as the number of sections increase, the risk of morbid adherence is bigger. Its risk is higher as well in cases of placenta implanted on a fibroid or a uterine septum. In previous surgeries on the uterus, as in myomectomy, DNC, and corneal resection of ectopic, the percentage of abnormal adherence of the placenta is increased. Also, it happens in previous history of intrauterine infection, and the percentage increases when the age of the patient is over 35. There are 3 types of abnormally adherent placenta according to the degree of invasion of the placenta to the uterine wall. Placenta accreta, in which the placenta adheres to the uterine wall. that is to say, invades the whole thickness of the decidua. And this is the most common type, accounting for 75% of cases. Placenta accreta, in which the placenta invades into the muscle layer of the uterus, accounting for about 15% of cases. And lastly, placenta percreta, in which the placenta invades the whole uterine thickness and may invade into the surrounding structures as the urinary bladder, and this accounts for 5% of cases. Definitely, placenta percreta is the most serious form. Investigations to diagnose a morbidly adherent placenta include ultrasound, color Doppler and 3D power Doppler, MRI. Regarding the lab investigations, we can do maternal serum alpha-fetoprotein and maternal cell-free fetal DNA, and both are elevated in cases of placenta accreta. All other investigations referred to the placenta previa are done as well, and this will be discussed in details in the face-to-face session. The picture on the left shows a two-dimensional ultrasound for a placenta previa centralis accreta. There are areas delineated by the white arrows showing invasion to the uterine wall. The picture on the right is for a color Doppler for a different patient with placenta previa centralis in a previous 2 cesarean section patient. As you can see, the vascularity of the base of the placenta is encroaching and invading the bladder wall. This is a case of straightforward placenta previa centralis percreta. The picture on the left shows an MRI for a placenta previa centralis in a primigravida patient. There is no invasion of the uterine wall, whereas the picture on the right side shows an MRI for a placenta previa centralis in a para 2 cesarean section patient showing evidence of invasion. You can see the irregularity of the wall of the bladder together with loss of the plane between the placenta and the bladder wall. Management of placenta accreta include same preoperative preparations as placenta previa. Most of the cases will end in a classical cesarean section and supravaginal hysterectomy. If the placenta is invading the bladder wall, sometimes partial cystectomy is needed as well. Sometimes, if it separates totally or partially, the placental bed bleeding is managed accordingly. You need to refer to the postpartum hemorrhage lecture. In some situations, the placenta, if it did not separate, can be left in place, but this carries a very high risk of postpartum hemorrhage and infection. Routine methotrexate or arterial embolization is equivocal in cases we leave part or all of the placenta. Follow-up is usually done by ultrasound and serum beta-HCG in these cases. Management of postpartum hemorrhage as a result of placenta accreta include uterotonic drugs and bimanual compression, uterine packing by gauze or balloon tamponade, B-Lynch procedure, compression sutures, or suturing an inverted cervical lip over the bleeding placental bed, uterine and internal iliac ligation. Sometimes, if all the above doesn't succeed to control the bleeding, a supravaginal hysterectomy is done. In the following 6 slides, there will be a case scenario followed by a set of questions. I would like you all to read the cases and try to think of answers to the questions. These cases will be discussed in the demo session. Case number 1, a 30-year-old patient, para 1 plus O, in her second pregnancy. She is now 21 weeks gestation and had a previous normal vaginal delivery of a living male 3 years ago. During her anomaly scan, they discovered accidentally that the placenta is partial placenta previa. The patient is asymptomatic apart from minimal spotting that happened in the second month of pregnancy. Case number 1 questions. How are you going to counsel the patient regarding her condition? How are you going to follow up this patient? If the patient developed an episode of bleeding at 28 weeks, what is your management to the case? And what are the complications that might happen if the bleeding was severe? Case number 2, a 25-year-old patient in her first pregnancy presenting to the emergency room at 32 weeks gestation with an attack of moderate vaginal bleeding. Her general condition is stable. The patient denies any previous episodes of bleeding and had irregular antenatal care visits. Case 2 questions. What is your first step in the management of this case? Mention a single investigation for the diagnosis of this case. Design a plan of management for this case. If at any point in your plan of management you will proceed to a cesarean section, what are the precautions you will take? Case number 3. A 35-year-old patient in her 4th pregnancy. She delivered 3 times before by cesarean section and has got 3 living males. She is 30 gestation and presented to the emergency room with severe attack of vaginal bleeding. She is a well-known case of complete placenta previa. Case number 3 questions. Outline your management for this case in a proper order. What medications would have this lady benefited from during her pregnancy? If this lady is a Jehovah's Witness, would there be any change in your plan of management? If you have any questions, please prepare them to be discussed in the face-to-face session. Thank you.